So much. So, good evening, everyone. It's an absolute pleasure to welcome you all to today's Portrait webinar series. We are so excited to see attendees joining us, not just from all across the UK, but even from overseas. So thank you for your time to be here. I am Gorkem. I've been working as an out-of-hours GP since completing my CCT. I recently took a very exciting role as a GP partner, and really exciting. So along the way, I've been fortunate to hold roles such as GP Registrar Representative, First Five Representative, and the chair of the Scottish First Five and GP Registrar Committee. Currently, I continue my work with RCGP as a faculty representative for Scottish Council, and I am an IMG representative as well. But my passion lie in medical education and sports medicine. Over the years, I had the privilege of working as a club doctor in multiple football clubs, and I contributed to major events like Commonwealth Games in 2022 and Euro 2024. And in 2024, I was honored to receive the Inspire Award for Early Career GP of the Year. That is an achievement that reflects the dedication and support of the fantastic teams and colleagues that I worked with. So here's to the West of Scotland Faculty Board. But that's enough of me. Let's get started with today's session. So this event is just for everyone. We have all walks of careers in the event at the moment. We have GP registrars, we have first five GPs just starting their career in an independent practice, experienced GPs with a wealth of knowledge, and fellows. So we do celebrate the diversity in our profession, and we tackle a lot of challenges. Speaking of the challenges, let me start by saying something that might spark a little bit debate later on. Are the GLP agonists wonder drugs? Are they game changer in obesity and diabetes care? But we are ready for the ethical and resource implications of this widespread use. Are we ready for it? Without further ado, let me introduce you to today's speaker, Dr. Kevin Fernando. He's an inspiring doctor who brings wealth of knowledge and experience to the table. It's my absolute pleasure to have him here.
Thanks.
So he is a GP partner in North Berwick Health Centre in Edinburgh, near Edinburgh, and he is also a content advisor for WebMD, Medscape Global and UK. He's an internationally renowned speaker, medical writer, specializing in type 2 diabetes, cardiovascular and renal metabolic care, and interpreting abnormal blood tests in primary care. Dr. Fernando has co-authored numerous peer-reviewed articles and created practical clinical tools like Medscape UK Primary Care Hacks, which is brilliant. It helps you every moment in your career and in the operation and the surgery. An active social media educator, he shares valuable insights for healthcare professionals and tutorials. Am I right? Tutorials. So he's been posting on X, YouTube, and TikTok. Over 20 years of experience, a master's degree in diabetes, and multiple fellowships. Dr. Fernando's contributions to primary care and medical education are truly outstanding. So I'd like to add, if during the presentation you have any burning questions, please use the chat section and we will answer your questions. Without further ado, Dr. Fernando, over to you.
Great. Thanks, Gorkem. Thanks for your very kind introduction. Yeah, and hello everyone. Thanks for joining me this evening. As Gorkem said, we're going to be covering a very hot, I would argue, the hottest of topics, Gorkem, isn't it? The GLP-1s, colloquially known, of course, as the skinny jab. These are not new drugs, again, as Gorkem's alluded to. In my practice, North Berwick, we've been initiating GLP-1s. I've been initiating them for 10 years now for people living with type 2 diabetes. But of course, what's changed the landscape over the last year or two, some of the GLP-1s are licensed for people living with obesity without type 2 diabetes. And that's what's driven a lot of the shortages that have been briefly mentioned, and also the widespread use. And again, not a day goes by without, I reckon, at least 5 or 6 private provider notifications to my practice telling me from an online pharmacist that they've started one of my patients privately on either Mounjaro or Wegovy. So it's something that's affecting us all. And the data keeps coming. You were posing the question, is this a wonder drug? Is this a panacea? Even just today, there was high quality data published for semaglutide about heart failure benefits. Yesterday, there was a review in Nature journal, one of the highest impact journals, talking about over 40 identified benefits of GLP-1s. So it's hard to avoid this class of drug, though I appreciate that some of you may not have, of course, the background of using them for diabetes, and you might be new to the class. So I'm going to go right back to basics in this session. And don't worry, I'll keep the conversation very balanced. I'll talk about some of these remarkable benefits, but I'll balance them importantly with the side effects. No drug is without harm, is it, Gorkem? So we always need to balance the benefits against potential side effects. And that's why I'm a wee bit worried, to be honest, with all these private providers starting it. Because some of my patients tell me all they need to do is self-report a BMI and they're posted out 3 months of a GLP-1. No counseling, no psychological, nutritional support, no goal setting. So it's something we need to be aware of. But then I completely understand huge workload implications. I mean, we've basically been told in NHS Lothian, we are not to take any responsibility, for all these private initiations. And I can understand that. I don't have the capacity either. But sometimes I have had to intervene because of potential safety issues, particularly in younger women of childbearing age who haven't been taught, discussed contraception, etc. So I'm going to cover that all. But as Gorkem said, feel free to ask your questions as we go along. The session's being recorded. I'm happy to share my slide deck as a PDF after as well. I'll share my contact details. Okay. So let me share my slide deck now. Okay, maybe not here. Okay, can you see a full screen there, Kirsty?
Yeah, we can see the slides. Thank you.
Yep, and the slides advancing. Okay, here we go. So I've called this session from HbA1c to BMI, use of semaglutide and tirzepatide in primary care. And as I said already, 10 years now I've been initiating GLP-1 specifically for my patients living with type 2 diabetes to help lower blood glucose, HbA1c, and secondary benefits of weight reduction. But the big change is we're now using it to support patients living with obesity reduce weight. Now, I appreciate there's a number of GLP-1s out there, but the 2 main ones used in the context of people living with obesity are semaglutide and tirzepatide. So that's why I've focused on them. So Gorkem, I'm going to start with a pop quiz for you. What's this picture of here? Why have I put this picture up?
I have no clue about it.
Anyone want to type in the chat box? I can't actually see my chat box, but Gorkem's going to help me out. Anyone know what that is?
Lizard saliva.
Lizard saliva. 5 out of 5 for Salil. So that is a Gila monster. So the Gila monster, the first GLP-1 you might remember was something called exenatide or Byetta. So exenatide was derived for a substance called exendin, which was found in Gila monster saliva. And I'll tell you what GLP-1 does in a minute. But Gila monsters only eat very frequently throughout the year. So they need to have very strong GLP-1 hormone to slow their gastric emptying to stop them being hungry throughout the year. So some clever scientist identified exendin in Gila monster saliva, looked very similar to human GLP-1, and that's how this class of drug was discovered. A really fascinating origin story. Of course, we no longer really use Byetta, exendin. We have GLP-1 analogs, so completely chemical synthesized. But another of many medications we use are either from plants or animals. And as I said already, this is a very hot topic for us. I just pulled out some of the headlines that have appeared online, in the newspapers over the last few months. Weight loss injections. How do drugs like Wegovy and Mounjaro work? UK regulator, the MHRA, tells us to watch out for obesity injection side effects. And the really controversial one, do you remember that one, Gorkem? Unemployed could get weight loss jabs to return to work. I don't know how,
That's really
I don't know who signed off on that one. And then even The Economist, the bottom middle one is from The Economist. It's not just about obesity. Drugs like Ozempic will change the world, the billion-dollar industry. But then the big hot topic, as you'll know, here, for all of us in Scotland, sadly, a nurse in Lanarkshire died who was on Mounjaro. I mean, it's very unclear. Of course, we've not been privy to all the medical details, to all the what's going on, but she was on Mounjaro. She appeared to get pancreatitis as part of multiple pathologies. And so, of course, that caused a lot of concern, didn't it, at the time? That was only in November or December, wasn't it? So very hot topic for us all in primary care. So Gorkem's given me a very kind introduction, so I'm not going to go through anything about myself again, apart from saying a long-standing interest in diabetes. I'm not just jumping on the bandwagon with the GLP-1s. As I said, I've been using them for 10 years, but how I'm using them has completely changed, even just over the last 2 to 3 years, okay? These are my disclosures. Again, I must disclose, this is a completely independent session, but I do work with the pharmaceutical industry. Particularly, I do have worked with Lilly and Novo Nordisk in the past to make GLP-1s. But this is a completely independent session, okay? And these are those primary care hacks that Gorkem also kindly mentioned. I work for Medscape 1 day a week, producing educational content for globally. And because it's such a hot topic, they asked me to put together a guide, which I co-authored with a colleague and buddy of mine, Ema Darcy, a GP in Northern Ireland. So you can access it from the QR codes on my slides. This looks at the 3 main GLP-1s used for obesity: liraglutide or Saxenda, semaglutide or Wegovy, and tirzepatide or Mounjaro. So I've got a page on how the indications, the dose escalation, and then importantly, the different brand names, the practical considerations, the side effects, the holistic approach to behavior modifications, women's health and incretin therapies, how to minimize side effects, follow up, missed doses, etc. So do have a look at this if you have some time. As I said, this is a completely independently produced resource by myself, not affiliated to any pharmaceutical company. So I do hope you find that helpful. That's why me and Ema put it together, just to try and make sense of all this information we're bombarded with about the GLP-1 analogs. And we've also done a number of other non-pharmacological hacks as well. I did this one on interpreting liver blood tests in primary care. I'm sure you're the same, Gorkem. Abnormal liver blood test, the bane of my DocMan inbox. Every time I see abnormal liver test, I just tick repeat 4 weeks and hope for the best. So I've tried to stop ticking repeat 4 weeks. So have a look at this if you have some time. And the one I co-authored this with my wife, actually, Gorkem, who has an GP with an interest in dermatology, management of acne in primary care, lifestyle and other issues. So again, just a quick signpost plug, if you don't mind, for my resources. Great. So let's talk about GLP-1. So what I'm going to take you through over the next 45 minutes or thereabouts, the mode of action of GLP-1s. As I said, I appreciate some of you will be completely new to the class, will not be familiar with them, whereas others maybe have quite a bit of experience in the world of type 2 diabetes and GLP-1s, but not so much obesity. And as I said, I promise I'll balance the benefits against the potential adverse effects, particularly those gastrointestinal side effects, which by far in 10 years plus use of using GLP-1s are the commonest side effects I've encountered for my patients. I'll talk about precautions for use and special considerations as well, and using GLP-1s in people living with type 2 diabetes. So the first, though, and arguably the most important slide, as we all know as HCPs, these jabs are not a quick fix, okay? Sadly, many of my patients think it's a quick, easy way to lose weight, but it's not. It needs to be part of that holistic package of care in supporting people living with obesity. All the big GLP-1 obesity trials in the placebo arm and the active GLP arm of the trial, they had nutritional support. They did resistance exercises. They had 500 calorie deficits. So it's not just about the jab. And I know we all know this, but we do need to remind our patients this is not a quick fix. It needs to be offered as a holistic package of care alongside behavioral modifications and other interventions such as physical activity, stress management, sleep health, and goal setting as well. And that's my main concern with these private providers. They're just not doing this. all they're doing is prescribing the drug with very little counseling and indeed follow-up as well. So do remember, and I know you all know this, it is part of a package of holistic care. And part of that package is that conversation with that person living with obesity. And it can be a very difficult conversation, can't it, Gorkem? We don't want to offend patients, but we are duty bound, aren't we? Obesity is now a major, as we know, cardiometabolic risk factor. It's also a risk factor for 13 different types of malignancy as well.
It's a public health emergency.
It's a public health, 100%. So we are morally and medically duty bound, I feel, to bring up the issue of obesity. Though I'm not saying it's easy. I'm sure we've all had consultations which haven't gone well when we try and talk about weight. So there's this lovely framework I wanted to quickly highlight for you from Diabetes Canada, and a great Irish GP called Dr. Michael Crotty, who I've had the pleasure of teaching alongside, the 5 A's of obesity management. Well worth having a look at this in your own time. It's a really good tutorial topic for your GP trainees as well. Ask, assess, advise, agree, and assist. So
we already have a question coming.
Oh yeah, go for it. Yeah.
So the question is, do we prescribe a generic semaglutide or as the brand name?
Don't worry, I'll come along. I'm covering all of that very shortly. So okay. I'll cover that just in a minute. Don't worry. So yeah, have a look at this framework. It's very good. And A for ask permission. It's a collaborative approach, isn't it, to managing obesity? Then we do need to assess individuals living with obesity. What is the severity? Yes, we tend to use BMI, but as many of you will be aware, the direction of travel is actually waist to height ratio. Because BMI, whilst it's a useful and well-recognized tool, is a fairly arbitrary tool of obesity assessment, isn't it? It presumes everyone's cube-shaped, I should say. Whereas waist to height ratio is a better predictor of future cardiometabolic complications of obesity than BMI. So in an ideal world, we should all have a waist size that is less than half our height, okay? So a normal waist to height ratio is less than 0.5. If you have a waist to height ratio of less than 0.5, you are at low risk of cardiometabolic complications. If you have a waist to height ratio of 0.50 to 0.59, you're at increased risk of cardiometabolic complications, such as type 2 diabetes, cardiovascular disease. And if you have a waist to height ratio of 0.6 and above, you're at high risk of cardiometabolic complications. Now, the other beauty of a waist to height ratio, you don't need to ethnically adjust it, okay? So unfortunately for people like me, and I think unfortunately for you, Gorkem, we're stuffed, aren't we? Because a normal BMI for people like me and Gorkem is 22.5 and below to reflect our inherent insulin resistance and our high-risk genetic pool. But you don't need to ethnically adjust waist to height ratio. So I need to aim for a waist to height ratio of less than 0.5, as do my Caucasian counterparts of my similar age to me. So a number of advantages. Sorry, I will come on to GLP-1s, I promise. But that is the direction of travel, waist to height ratio. Then, of course, we need to advise about the health benefits in a collaborative fashion. No, fat shaming, no blaming. Then we need to agree realistic SMART goals. We all know that SMART acronym, realistic goals and time related goals as well. I mean, lots of my patients say they want to lose 5 stones by the summer. We've got to be realistic, don't we, as well? Reset expectations. And then assist. How can we help that person? Can we refer them to the weight management service? Can we consider medication? What are the barriers? So definitely worth having a look at this framework with 5 A's of obesity management, okay? Okay, now, as I said, but let's get on with GLP-1s. So what are GLP-1s? Well, GLP-1 stands for glucagon-like peptide 1, okay? It's what we call an incretin hormone. I'm sure many of you will have been hearing this term a lot. So what are incretin hormones? Incretin is an acronym. It stands for intestine secretion insulin. So it's a hormone that secretes insulin, triggers the secretion of insulin in response to any food, nutrient, or glucose intake, okay? So the main ones we know about are GLP-1. So liraglutide, dulaglutide, and semaglutide. These are three commonly used GLP-1s we've been using for type 2 diabetes for many years. So this is a nice little infographic I found online to demonstrate how these drugs work, or how GLP-1 works. So many of you have probably had dinner already before this webinar. When that nutrient, that glucose load hits your gut produces GLP-1 hormone from the L cells in the intestine. What that GLP-1 does, it directly stimulates the beta cells in the pancreas to secrete insulin. And of course, what that insulin does, it brings down the rise of glucose associated with that meal. So in particular, it has an impact on postprandial hyperglycemia, okay? So it lowers glucose in a glucose-dependent fashion. So that's why this class of drug has a low risk of hypoglycemia. GLP-1 only works when there's a nutrient load in the gut, okay? GLP-1 also stimulates the alpha cells to reduce glucagon secretion. What are the effects of glucagon? Glucagon causes hyperglycemia, doesn't it? So by reducing glucagon secretion, you're also lowering blood glucose levels. GLP-1 hormone also has a local effect in the gut to slow gastric emptying, to slow the passage of food through the gut, to slow the absorption of glucose from the gut, to also help lower blood glucose. But by slowing gastric emptying, you start to feel full. And that's one of the key effects of this drug. It increases our feeling of being full. It increases satiety. It reduces appetite. And that indeed is the last mechanism of action I wanted to highlight. GLP-1 crosses the blood-brain barrier and directly affects the hypothalamus to increase satiety and reduce appetite, and hence result in weight reduction. So you can see it has a number of beneficial effects for people living with type 2 diabetes in terms of lowering blood glucose, but also in terms of helping reduce weight. And it's well known that people living with type 2 diabetes produce less GLP-1 than people without type 2 diabetes. So that's why GLP-1s have been such an effective drug option for many patients living with type 2 diabetes. And to be honest, for many years, last time Gorkem kindly asked me to speak, I spoke about SGLT2. So for many years, my standard practice has been for type 2 diabetes, lifestyle, metformin, SGLT2, and then GLP-1, okay? So these, as I said, these are the commonly used GLP-1s over the last few years. Liraglutide, brand name Victoza, someone mentioned, dulaglutide, brand name Trulicity, and semaglutide, brand name Ozempic. The new kid on the block is something we call tirzepatide, or brand name Mounjaro. So what on earth is tirzepatide? Well, tirzepatide is actually a combination of two incretin molecules. It's GLP-1, but also another incretin gut hormone called GIP, glucose-dependent insulotropic polypeptide. We'll just call it GIP for short. And GIP basically has much the same effects as GLP-1. It's found in various places in the body. It also stimulates the pancreas to secrete insulin. It also slows gastric emptying. It also crosses the blood-brain barrier. And what they've found is this combination of GLP and GIP, tirzepatide, has been particularly effective for glucose lowering, for people living with diabetes, but also for weight reduction as well, okay? So that's what we mean when we talk about incretin hormones, or GLP and GIP. These are gut hormones. These are not new. We've known about these gut hormones for a very long time, but it's only in the last 10 years that we've managed to engineer GLP-1s, partly driven by the finding in the lizard saliva. And then it's only more recently that GIP has been added on alongside GLP-1. So does that make sense, Gorkem?
Absolutely.
Good stuff. So as I said, I've been using GLP-1s for type 2 diabetes for many years now, 10 years. And they have been largely injectable. Originally, the original Byetta was a twice daily injection. Then came along Victoza, once daily injection. And then we had Ozempic, Trulicity, which were once weekly injections. But also, as you'll know, we now also have oral semaglutide, or Rybelsus, which is an oral GLP-1. So no wonder we're all a bit confused in primary care. Semaglutide, as I'll show you shortly, has 3 different brand names. So not just for us as HCPs, my patients are incredibly confused as well, especially the ones that are trying to buy it online, because only certain of these products are actually licensed for obesity. But going back to diabetes, we can use these drugs for diabetes as monotherapy if metformin is contraindicated, in combination therapy alongside other oral drugs and insulin, okay? And another beauty of these class of drug, it can be used in all stages of hepatic impairment, and actually many GLP-1s can be all used all the way down to even end-stage kidney disease as well, down to CKD stage G5. So they're quite versatile drugs as well. So that's why it's been a staple therapy of mine for many years for type 2 diabetes. So this is another hack of mine. Sorry to plug it again, but it tells you how to prescribe diabetes drugs, particularly the GLP-1s, in the context of renal impairment. So if you have some time, have a look at that one as well. But as I said, it's quite easy with GLP-1s, certainly compared to some other classes of drug. Most GLP-1s you can prescribe down to CKD stage G5, so an eGFR of down to 15. Okay. So the benefits, as I told you, in type 2 diabetes, these are potent glucose-lowering drugs with secondary benefits of significant weight reduction and, as I've said already, overall a low risk of hypoglycemia. But over the years, even in the world of type 2 diabetes, we've had some other interesting benefits come up with the GLP-1s. Liraglutide, Victoza, semaglutide once weekly, Ozempic, and dulaglutide, Trulicity, have all also demonstrated significant reductions in MACE, major adverse cardiovascular events, in people living with type 2 diabetes. So that's why some of our cardiology colleagues have been starting this, not just for the weight reduction and the glucose lowering, but for cardioprotective benefits as well. So you can see it's always been quite a popular choice of drug for patients living with type 2 diabetes. And interestingly, hot off the press, just a couple of months ago, semaglutide once weekly, Ozempic, has also demonstrated significant reductions in MARE, major adverse renal events, in people living with type 2 diabetes. It was a study called the FLOW study. So later this year, semaglutide once a week, Ozempic, will be a new pillar of therapy for diabetic kidney disease. So it's incredible how the landscape is changing, the pace of evidence. It's really difficult, isn't it, for us as GPs, nurses, pharmacists in primary care to keep up to date. But the big change, of course, the game changer, as you said, Gorkem, is we are now using GLP-1s and GLP-GIP for weight management, even in people without type 2 diabetes. And what we've definitely seen in the studies, when you use GLP-1s in people without diabetes, you get even more potent weight loss. Some of these drugs I've mentioned, you're seeing up to 24% reduction from baseline body weight in trials, albeit, but still pretty impressive numbers, isn't it? And again, some interesting other benefits as well. So again, semaglutide, you did call it the wonder drug, didn't you? Has demonstrated, even in people without diabetes but living with obesity, significant reductions in major adverse cardiovascular events and significant benefits in fatty liver disease, or the new terminology we talked about briefly last time, MASLD and MASH. As you might know, NAFLD is now being renamed MASLD, Metabolic Dysfunction Associated Steatotic Liver Disease. And I know you're all rolling your eyes virtually there. I can't see you. But it's a name change I agree with, because what it's essentially telling us, fatty liver disease is not primarily a liver disease. It's primarily a metabolic disease. It's the liver's manifestation of the metabolic syndrome. So semaglutide has benefited that. And then again, very recently, tirzepatide or Mounjaro has also demonstrated additional benefits, again in fatty liver disease, but also in sleep apnea. That was just last month. So it's a rapidly changing landscape. And I work 2 days in practice, but pretty much the rest of my time, Gorkem, is keeping up to date. There's no way I could keep up to date if I worked as a full-time GP. It's such a rapid change. So that's why a big part of my role is medical education. I'm fortunate I get to go to a lot of the conferences, etc. So a big part of my role, I feel I'm duty bound to relay all these practice changing messages. So here's, I think you've had a couple of questions on this. This is definitely what I get asked about all the time, not just from my colleagues, but from patients too, the brand confusion. Because let's start with Ozempic, Rybelsus, and Wegovy are all different brand names for semaglutide. And I know what you're thinking. What on earth? What on earth are they thinking? So let me talk you through what the differences are. They are all the same molecules, so they are all semaglutide. So Wegovy is specifically the preparation approved for weight management and cardiovascular risk management in people living with overweight or obesity. And Wegovy, so when we're using it for obesity, you can use it up to 2.4 milligrams weekly, okay? Whereas Ozempic, which many of you are familiar with, this is the brand I've been using for 6-7 years. Ozempic is the brand that we use for the management of hyperglycemia in people living with type 2 diabetes. And the doses we can use for hyperglycemia are up to 2 milligrams weekly. So slightly different from the weight management dose. So you can see why this causes confusion. And then we have Rybelsus. Rybelsus is daily oral semaglutide, and that doesn't currently have a weight management license. It's only to be used for the management of hyperglycemia, and it's a up to a 14 milligram once daily dose, and again only for people living with type 2 diabetes. Now the reason why I'm going through this in detail is I have patients who are buying Rybelsus online for weight management, and it doesn't have a license for that. You do get some weight if you're lost with it, but certainly nothing compared to, say, Wegovy. So we do need to counsel patients appropriately if they are sourcing it from illicit or other sources, that the brand for weight management is Wegovy. Though that said, as you know, many people are just sourcing Ozempic and doubling up doses or changing doses too. But it is a bit of a minefield out there, and we do need to be aware of that. So remember, 3 different brand names for semaglutide. What about Mounjaro then, or tirzepatide? So the brand name, tirzepatide is a generic name, Mounjaro is the trade name. So confusingly, in the US, typical US, don't talk about the US at the moment though. the
Especially
US,
not in these 2 days.
yeah, I know. The US, the FDA in US have approved Mounjaro for the management of hyperglycemia in adults living with type 2 diabetes. But if you're using tirzepatide for weight management, they've branded it Zepbound. Ugh. And that's purely for billing reasons. You know what the healthcare system is like in the US. So if your patients come to you because they've sourced Zepbound, that is what they're talking about. It is tirzepatide, it is Mounjaro. It's exactly the same drug. And both indications, hyperglycemia, type 2 diabetes, or weight management, the dose is thankfully the same, up to 15 milligrams once a week. Okay, but just don't be caught out about that if someone comes to you looking or asking about Zepbound. Okay, thankfully in the UK, tirzepatide is only branded as Mounjaro, whether you use it for weight management or type 2 diabetes. So at least the company got it right here in the UK, and that should hopefully reduce the confusion. But as I said, my patients are definitely sourcing this from abroad as well. So just look out for that.
Yeah.
And then I think you said,
comment.
Yeah. Well, can I just do this bit on liraglutide?
Yeah.
Because Gorkem, I think one of your colleagues asked, and then asked me the questions. No problem.
Okay.
So those are the main ones we use, semaglutide and tirzepatide. But there is still use of Victoza and Saxenda. So what are these drugs? Well, these are brand names, different brand names for liraglutide. Okay. So Victoza is what, again, I've been using for 10 years nearly now, and that's liraglutide for the management of hyperglycemia in people living with type 2 diabetes, up to a dose of 1.8 milligrams once a day. Whereas Saxenda is the version of liraglutide licensed for weight management, and that's actually up to 3 milligrams once a day, and that can be used in people without diabetes as well. Okay, and then one of your colleagues, I think this is what they were getting at. As of December, your colleague is very hot off the press. As of December, we now have an authorized generic, I should say, of liraglutide called Diavic. Because, as I said, liraglutide is well over 10 years old now, so its patent has expired. So this is going to cause more confusion, isn't it, in primary care? And the reason Victoza Saxenda is still being used was because of all the supply issues last year. When people couldn't get hold of tirzepatide, it was new anyway last year, Ozempic, that's what drove an increase in Victoza and Saxenda prescribing. So hopefully that's helped demystify some of the brand confusion for you all there. So why don't you fire away with the questions, Gorkem?
Well, look, I think the brands will attack on this on these molecules, and we will possibly see more brand names in the next 5 years. The first question was, do we prescribe the generic semaglutide, or do we prescribe the brand names?
Yeah, so at the moment we need to prescribe by brand because of the different license indications. So brand prescribing. Well, I suppose we can talk about this in Q&A. As you know, and certainly in Scotland, we can't prescribe it within the NHS at the moment for obesity. We do have this national Scottish GLP-1 consensus, which just suggests everyone with a BMI of 39 and above and one weight-related comorbidity. The Scottish government do want us to prescribe it, but that's not been accepted by any health board in Scotland because of the obvious cost implications. But I would prescribe by brand name at the moment, yes.
All right, and there's another question, same way. What accounts for the differences in indications for the different brands of semaglutide?
It's whether you have whether it's for obesity or type 2 diabetes. So Rybelsus is oral semaglutide, and that's only to be used for type 2 diabetes, okay? Wegovy is the weight management brand of Ozempic, and that goes all the way up to 2.4 milligrams, whereas Ozempic is the type 2 diabetes version of semaglutide. I know it seems unduly complicated, and it is, but it's to do with the different dosing, because the obesity studies were done all the way up to 2.4 milligrams, whereas the original Ozempic hyperglycemia studies were only done to 1 milligram and only laterally to 2. So the different brand names and license indications reflect the different doses as well. So that's partly what, okay?
Yeah. And is tirzepatide showing greater benefits for weight loss than the standard GLP agonists?
Yeah. So in a nutshell, yes. And I've been using tirzepatide for a year now for people living with type 2 diabetes, of course. I haven't been using it for obesity. And I've definitely, objectively speaking, and I've used both molecules, up till tirzepatide, my main one was semaglutide. I'm seeing more weight loss with tirzepatide compared to semaglutide. Yeah.
Okay, so do you want to continue, because we will have more questions?
Yeah, I'll continue. Yeah, no problem. So, I mean, I've got to talk a bit more about benefits again later on, but let me focus on some of the side effects, because I get loads of questions about this. Understandably, a lot of concern about things like the GI side effects. And again, very apt, because just in October of last year, MHRA published an alert for us, GLP-1 receptor agonist, reminder of the potential side effects and to be aware of the potential for misuse. And I think I saw somewhere in the chat box, one of your colleagues said they had a patient who'd been prescribed it with a BMI of just 20. That is misuse. That is not an appropriate, indication for use of GLP-1. So let me talk about some of the side effects now, okay? So going back 10 years, this has always been in the US SPC, Summary of Product Characteristics, but not the UK. But I thought I'd better highlight it. All GLP-1s are actually contraindicated in anyone with a personal or family history of MEN2, multiple endocrine neoplasia 2, or medullary thyroid cancer. But these are incredibly rare conditions. I mean, I don't have any patients on my books with these conditions, but just be aware that is a contraindication, but mainly in the US. But I do get asked about this a lot, so that's why I've just put it in on this slide, okay? But by the commonest side effect I've seen in 10 years of prescribing GLP-1s are the gastrointestinal side effects, okay? I reckon up to, officially it says 10%. I reckon 30 to 50% of people will get some sort of GI adverse effect. And that's the whole range of GI adverse effects, okay? So that could be nausea, vomiting in severe cases, diarrhea, constipation, abdominal pain, distension, bloating, dyspepsia, flatulence, belching, okay? So I would reckon probably up to 1 in 3 will get some degree of GI side effects. However, these mostly occur whilst the dose is being escalated, and importantly, and we do need to reassure our patients, they usually fade with time. So as always, the mantra with GLP-1s is start low, go slow. That's also my mantra with metformin. It's my mantra with many drugs, isn't it?
In bed.
Okay, so start low, go slow. And typically, as I said, the GI side effects are mostly mild to moderate in severity. But those are by far the commonest adverse effects we'll see with the GLP-1 receptor agonists, okay? So as such, because they cause these GI side effects, we need to use them in caution in people with severe GI disease. So inflammatory bowel disease, Crohn's disease, ulcerative colitis, not absolute contraindication, but I would definitely be very cautious. And also diabetic gastroparesis, gastric autonomic neuropathy, not an absolute contraindication, but use with caution. But remember, the side effects are dose dependent. So consider slower dose escalation. So those of you familiar with the drugs, don't step up too quickly to the next dose increment. Just park at that lower dose, let that individual get used to the side effects. I've got some other strategies to share with you, and then escalate. Or another strategy I use is a drug holiday. So even if you've got to a therapeutic dose, 5 milligrams of tirzepatide, but they're still getting GI side effects, just stop the drug, take a drug holiday for 4 to 6 weeks, and then restart, perhaps at a lower dose. That can be a useful strategy to help tolerability as well. But other physical strategies, I've got a nice infographic here from a paper that was published recently, advising patients to significantly change their eating habits. So eating smaller portion sizes more frequently, eating more slowly, and stopping eating as soon as you feel full. I mean, these are all common sense things we should all be doing, Gorkem, anyway, shouldn't we? Smaller portion sizes, eating more slowly. I'm definitely a hypocrite. You know, the 5 minutes we get for lunch in general practice, stuff down my lunch. But ideally, I should be eating more slowly to allow time for those baroreceptors to realize I'm feeling full. So eating more slowly, only eating if I'm hungry, smaller portions. Also, stopping, as I said, as soon as you feel full, stop eating. Remember when growing up, I'm sure you were the same, Gorkem, we had told to clean the plate, you know. But no, that is bad practice. That's harmful practice. We should stop eating as soon as you start feeling full. And then avoid eating late at night, because if you eat very late at night, because of the slowed gastric emptying, that food just sits in your gut overnight and you feel sick overnight or sometimes vomit. So avoid eating late at night. Avoiding ultra-processed, spicy food or very sweet, sugary food, that can also worsen the GI side effects as well.
I think that's one of the things. We are just hoping that this medication will not overcomplicate the common sense.
Common sense, yeah, absolutely. As I said, a lot of these eating habits we should all be doing. Absolutely. And good hydration. Especially if constipation is an issue, good hydration. So I usually tell patients, if you're on a GLP-1 or an SGLT2, try and drink 2 to 2.5 liters of clear fluids daily, not including tea, coffee, or alcohol. So I know that's slightly hypocritical. I don't do that myself. And it's maybe aspirational, but they aim for 2.5 liters. Hopefully they'll get somewhere near that. So that can be useful. So these are all useful strategies to help mitigate. And again, common sense lifestyle, regular exercise. Again, I've tried and avoid too heavy exercise. That kind of, worsen GI side effects. But regular, brisk exercise can also help as well. So as you said, common sense things, really. And in some cases, I have considered drugs. If people have got really disabling GI side effects and there's a really compelling reason I want them to continue on the GLP-1, I will consider short-term use of PPIs, just a low dose of omeprazole, 10 milligrams, antiemetics. I usually tend to use something like cyclizine or domperidone. Though domperidone, of course, it's a gastric motility agent, as you know. Or if it's constipation, you know, a macrogol or another laxative's fine. Or if it's constipation, if it's diarrhea, antidiarrheal medications. But be clear with your patient. These are just short-term use to get them through the dose escalation period, get them used to the side effects, okay? And again, on that subject of delayed gastric emptying, because of the slowed gastric emptying, there is the potential actually to impact the absorption of co-administered oral medications. But really, the official line from all the manufacturers of the major GLP-1s, no dose adjustment is required for most oral medications. That said, if your patient is taking a narrow therapeutic index medication, digoxin, lithium's the big example, warfarin, maybe even the DOACs, you might want to consider closer monitoring or counsel about, you know, side effects of drug toxicity. But very much use our clinical judgment. There's no mandated increased monitoring, etc. So use your clinical judgment, okay? And sick day guidance. You've all heard me talk about sick day guidance for SGLT2s. Sick day guidance is not such an issue for GLP-1s, mainly because they're just once a week, and most illnesses have resolved, haven't they, by a week. So you might want to consider sick day guidance, particularly if people have an intercurrent dehydrating illness such as diarrhea and vomiting. And really, all I counsel patients is just to miss out the next injection. That's really all, and then start the week after. And that's really all you need to do. But it's not perhaps quite as pivotal as with the SGLT2 inhibitors. Okay.
But we have some questions. Can I?
Yeah, go for it. Yeah, go for it.
Mm-hmm. So we had questions from like a bit earlier as well. So if the patient is on metformin, DPP-4 and SGLT2, and their HbA1c risen to 116, she's waiting for bariatric surgery. They have not had diabetic retinopathy screening. Are we able to prescribe GLP agonists at this point?
So excellent question, and park that question, Usman, because I've got a bullet point specifically about diabetic retinopathy. So I'll answer that first part later, but I will answer the second part. I see you've asked about how can we tell if this is reduced beta cell function and needs insulin. Excellent question. And I'm seeing this more and more. People with long-standing type 2 diabetes, high HbA1cs. So this is ideally where we need to check things like C-peptide. So if you're not familiar with C-peptide, C-peptide is a byproduct of the beta cells when the beta cells produce insulin. So if your beta cells are not producing a lot of insulin, you have very low C-peptide levels. So people with type 1 diabetes have zero C-peptide or very low because they have autoimmune destruction of the pancreatic beta cells. So at the moment, I can't check C-peptide easily in primary care. I need to get my secondary care colleagues. But are they losing weight? That's also a sign of insulopenia, and that person needs insulin as well. So these are the sort of clinical and biochemical factors to try and figure out if actually this is insulopenia and reduced beta cell function. And rather than a GLP-1, that patient needs insulin, as you're alluding to. But excellent question there. Great.
That's great. And so we mentioned that we cannot prescribe in NHS Scotland at the moment, but is it allowed to prescribe GLP-1 in England?
No, not in England either. Certainly, all my diabetes buddies in England have got similar restrictions on the local basis as well. I mean, NICE are very keen that every primary care in England do prescribe this, but the pathway is still not being delineated clearly. So not at the moment. So the bulk of prescribing for obesity is done in tier 3 and 4 services, in secondary care, and also in private services, of course. Yep.
And do these drugs need to be used long-term for weight loss benefits, or can they be stopped?
Excellent question. And this is the $64,000 question. My obesity colleagues definitely look at this as secondary prevention of obesity. So like if you have a heart attack, you start on a statin and you stay on that lifelong, don't you? Regardless if you have a heart attack again. And that's what they're saying is with obesity. Because many people living with obesity have pathological changes in appetite, other hormones. Some of you will be familiar with set point theory, where after significant weight loss, your body launches essentially counter-regulatory physiological and hormonal changes to put you back to your previous weight. And some people can manage that with lifestyle change, but other people do need to continue. But there's cost implications, isn't there, Gorkem? If we consider incretins lifelong, like we do statins, it would bankrupt the NHS. So, and there's no doubt, though, the studies show once you stop incretins, weight loss goes back. Doesn't quite go back to baseline, but it heads back towards baseline. So that's why for the nice TA for semaglutide, they have initially signed off 2 years use of Wegovy for weight loss. But that was dated March 2 years ago. So what people who are on it this March, what are weight management services going to do? Stop it or continue it? It's going to be a really interesting time, but huge financial implications there. Yeah.
Absolutely. And what are the advantages of Mounjaro or Ozempic for patients with obesity plus type 2 diabetes? Which one would you use first?
Yeah. Well, I've got to be honest, and I've used them both. Ozempic's very good, but because Ozempic still had supply issues for most of last year, my GLP-1 of choice at the moment, GLP-GIP, is tirzepatide, is Mounjaro. It does what it says on the tin. It lowers blood glucose, secondary benefits of weight loss. And as I said, I did declare my conflicts at the beginning. I've done work with both Novo and Lilly, so I must declare that. But that was my rationale, was there was no supply stock issues with Mounjaro. So that's why I've gone with Mounjaro.
And there's a question that I am really curious about as well. Is it safe to offer these medications, Mounjaro or Ozempic, to someone who has had gastric bypass surgery and have regained back the weight?
So this is something I asked about last year, and it is actually, it tends to be done in secondary care services, weight management services, but I've started doing it a little bit in primary care for my patients who've type 2 diabetes, who've had gastric bypass surgery. So you can use them. The answer is yes. Then it's gastric bypass bariatric surgery is not a contraindication, and actually it can be quite a useful strategy for people who have regained weight after bariatric surgery. Yep.
Yep, that's brilliant. I'll just let you go on with your presentation, and I'll just, keep colliding questions and keeping questions, and I'll ask you on the way, if you like.
Okay, yep, no problem. So another important topic, women's health and incretin therapies. And again, I've already alluded to this. I've been really worried about some of these private providers starting women of childbearing age on incretins, on Wegovy or Mounjaro, and not talking about contraception. Because the bottom line is, as you can see, this is a box from my primary care hack. Incretin therapies are not recommended during breastfeeding and pregnancy, and women of childbearing potential should use contraception. Okay, so a very important key take-home message for us. And if women are planning pregnancy, the SPC for liraglutide just discontinued before attempting to conceive. Remember, it's a once daily drug, so short half-life, it's out your system pretty quickly. Semaglutide, the manufacturers say discontinue at least 2 months before attempting to conceive, and tirzepatide discontinue at least 1 month. But the key thing is have the conversation. In a younger lady of childbearing age, ask them frankly, what are their plans about having a family? Because it's not just incretins, is it, Gorkem? Statins, SGLT2s, many of the drugs we use for cardiometabolic disease are not licensed for use in pregnant women or women attempting to conceive, okay? And in fact, for tirzepatide, there's specific advice for the oral contraceptive pill. So for women with a normal BMI, and most women going on tirzepatide, you would hope, don't have a normal BMI, apart from the one that someone typed in the child box, no dose adjustment of the oral contraceptive pill is required. But for women who are living with overweight or obesity, the advice from the manufacturers of tirzepatide is to switch to a non-oral contraceptive method. So LARC, long-acting reversible contraception, or barrier method of contraception upon initiation of tirzepatide, or every dose escalation for 4 weeks. So again, this is, in my experience, is just not being discussed by some private providers in women of childbearing age. So very important take-home message for us. Okay. So other precautions for use. Remember I showed you, sadly, that tragically, that nurse who died in Lanarkshire. So she appeared to have pancreatitis as part of a constellation of complications. So what is the official line about pancreatitis? Again, this is not new. 10 years ago, when I started prescribing GLP-1s, I was warned about a rare or uncommon risk of pancreatitis. So it's currently quoted at less than 1%, okay? And even if your patient has a history of pancreatitis, maybe gallstone-induced pancreatitis in their younger years, it's not an absolute contraindication. We can use it with caution. However, if you do see someone on an incretin and you suspect pancreatitis, we do have to definitely stop it, okay? Similarly, acute gallbladder disease is also a potential issue. We know any modality that causes a lot of weight, even very low calorie diets where you lose a lot of weight quickly, that can cause gallstones. And we've seen that with incretins too. Any significant or rapid weight loss can increase the risk of gallstones. But again, not a contraindication. If we do suspect gallbladder disease in anyone on Wegovy or on Mounjaro, just do what we would normally do. Consider an ultrasound, gallbladder imaging, and appropriate clinical follow-up. But again, uncommon, less than 1%. But this is the biggie that some of you may not be aware of. Again, over the last couple of months, there's been increasing concerns about possible pulmonary aspiration in people on incretins undergoing general anesthesia or deep sedation. And that's because of the slowed gastric emptying, isn't it, Gorkem? Slowed gastric emptying increases the risk of residual gastric content, increasing the risk of pulmonary aspiration. And why are many of my patients going on to incretins privately? To lose weight, so they're eligible for major surgery, such as hip replacement or other abdominal surgery. So my anesthetist colleagues very much want to know if our patients are either we're prescribing it or if they're on it privately. So this has only come to light in the last couple of months. Hot off the press, earlier this week, we've had in Anesthetic Journal, we've had some guidance on when to stop incretin therapies before general anesthesia. It's at least a week to 2 weeks. To be honest, I haven't read the full document yet. I've had quite a bit on my plate this week, but it's something we all need to be aware of, the pulmonary aspiration, and it's unclear the incidence of it, but do be aware of that. Now, special considerations in people living with type 2 diabetes, and this is where I'm going to come on to the retinopathy that your colleague asked about just a few minutes ago. So let's start with hypoglycemia. I've told you already, the risk of hypoglycemia is low with incretins by themselves, but if you're adding on GLP-1 alongside insulin or sulfonylurea, then of course that background risk of hypoglycemia is much higher. So if I'm adding on a GLP-1 to insulin, I proactively drop the insulin dose by about 15 to 20% to preempt any hypoglycemia. I hardly use SUs these days, sulfonylureas. Mainly use it for rescue therapy or for steroid-induced hypoglycemia. But if my patient happens to be on an SU, I'm going to add in a GLP-1, I would stop the SU and replace it with the GLP-1 to minimize the risk of hypoglycemia, okay? And on that note, if we are adding on GLP-1s to insulin, the MHRA warned us back in 2019, actually, that we mustn't too quickly reduce insulin or stop it alongside GLP-1s, because that can actually trigger DKA in some circumstances. So that's why I just cautiously reduce it about 15%, the insulin dose. Just do that stepwise and slowly with careful self-monitoring of blood glucose, or ideally CGM, continuous glucose monitoring. And here's that retinopathy then issue that your colleague asked about. And again, this is not a new issue. We've known about this for about 6 or 7 years. It was a semaglutide study actually called Sustain 6, which showed significant improvements in major adverse cardiovascular events in people living with type 2 diabetes with semaglutide once weekly, but it showed a small but significant worsening of pre-existing diabetic retinopathy if you brought down the HbA1c too quickly, okay? So that is the key here. Back in the day when that study was published, it was unclear whether this was an effect of semaglutide itself. But what studies have told me, and what the literature tells me, is actually anything that brings down HbA1c too quickly can worsen pre-existing diabetic retinopathy. So again, that mantra comes here again. Start low, go slow. So the expert consensus tells me I should use GLP-1s or GLP-GIP with caution in people who have pre-existing diabetic retinopathy, particularly those who are under active eye clinic follow-up, who have an HbA1c above 91 and who are currently being treated with insulin, okay? So in these patients, GLP-1s are not contraindicated. So your colleague was asking me about someone with a HbA1c of 116. So not contraindicated, though as I do agree with your colleague, maybe that individual actually needs insulin. But if I was going to start a GLP-1 on that individual, I would very much start low and go slow. And I ideally would like to make sure they've had a diabetic eye screen within the last 18 to 24 months. Okay.
So just very relevant here, what would be considered too quick reduction of HbA1c?
Yeah, so this is a clinical judgment as well. So, bringing down HbA1c by, a percent or more, 1% plus in a month is probably too quick, I would say. So I would aim for 11 millimoles, 1% over at least a couple of months, a more slow reduction in HbA1c. So just maybe initiate the lower doses of Ozempic or of tirzepatide, and just park at the lower doses and just bring it down more slowly before ramping up to the higher doses of these drugs. Yeah.
And is it normal for the patients to complain about severe tiredness?
And, hyperglycemia itself causes fatigue, absolutely. So if you've got someone with an HbA1c over 91, certainly over 100, that in itself will cause fatigue, absolutely. Yeah.
But when they are on semaglutide or...
Oh, sorry. So I've got to be honest, tiredness is not something patients having GI side effects, which I mentioned, but fatigue, tiredness, I've got to be honest, it's not something that's been mentioned to be a lot by my patients I've started GLP-1s on.
Okay. And so there's a brilliant question. Are the financial concerns short-sighted, given the cost of the obesity to the health service?
Oh, I mean, that's the elephant in the room, isn't it? I mean, we cannot afford the widespread use of this drug for everyone. I mean, the nice TA is everyone with a BMI of 27 and above. If we started this for everyone in the UK or even just Scotland with a BMI of 27 and above, we'd be bankrupt, wouldn't we? The NHS would be bankrupt. So, I personally agree with the Scottish GLP-1 consensus. Starting at the higher BMIs with significant comorbidities such as diabetes, sleep apnea, fatty liver, and expanding from there is the best way forward. Absolutely.
Considering the highest patient population who's not going to the work or having disability to the work is generally joint pains, back pains, and they are mostly connected to the obesity. Yes. So would it be a financial gain for the governments?
Oh, 100%. Yeah, 100%. I mean, if people can lose weight, we can help return to work. If obesity is a big driver why people are not able to work, yeah, absolutely. But of course, we don't have that data yet, don't we? I mean, the cost-effective studies are only based on 2 to 3 years worth of data. We don't really have a lot of the data for the impact on reducing comorbidities such as sleep apnea. But once we have that data, once we have the cost effectiveness, then yeah, absolutely, that's a game changer, isn't it? Yeah.
Yeah. And how about the TSPs? I'll just let's shorten it a little bit. To those normal BMI with high HbA1c.
Yes.
So I missed the beginning of that question. The tirzepatides to those with normal BMI with high HbA1c.
Yeah,
is there a risk to that?
Yeah, no, that's fine. Yeah, and I've done that as well because yes, we're mainly focusing on weight in this webinar, but tirzepatide, Ozempic are potent glucose-lowering drugs. So, I mean, I've seen even over the last year drops of 2% in HbA1c plus. So yeah, we shouldn't just reserve it for those who are overweight. We mustn't forget, one of the key abnormalities in type 2 diabetes is hyperglycemia, isn't it? So we need to treat the sugar as well.
We shouldn't forget the point.
Yeah, absolutely.
Okay. Please go on.
Okay.
I have a lot of questions. I'm trying to just,
that's great.
Not build them up completely.
To be honest, I'm nearly done now anyway. So follow up. So again, this is something that's done poorly by private providers. Private providers send out the medication, don't do any counseling and don't do any follow up. Remember, it needs to be offered as part of a holistic package of care, starting the drug, following up, and considering stopping as well. So it needs and this is where we just don't have the resources to do this, do we, Gorkem, in primary care? Even our weight management colleagues in secondary care will struggle to provide long-term, multi-component, multimodal, multidisciplinary follow-up. So by this, I'm talking about psychological support, nutritional support, physical activity support. We just don't have the resources to do that, do we, in primary or indeed secondary care. And we need to reevaluate continuing it. So really the official line is if people have lost less than 5% of their starting body weight after 6 months of the highest tolerated dose of tirzepatide or semaglutide, then we should consider stopping it, actually. So we need to have these conversations. But you can imagine patients are unkeen to stop it. I mean, I suppose it's different privately. They're paying for it anyway. But if we are going to start it in the NHS, we need to be very clear on starting rules, but we need to be very clear on stopping rules as well if it's not working, because these, as we've said on a number of occasions, are expensive drugs. Physical activity is important, not just for weight maintenance, but maintaining muscle mass as well. Because one of the big early concerns was with all the colossal weight loss with the GLP-1s, a lot of muscle loss too. To be honest, that's not really been borne out in my own clinical experience, but I do reinforce the importance of physical activity and particularly resistance exercises as well, to help maintain muscle mass. So that needs to be counseled as well. And, counseling about and supporting mental health disorders. We know mental health disorders are very common alongside obesity. And it's mixed evidence, albeit, but there is some evidence that incretin therapies may increase the risk of mental health disorders and suicidal behaviors too. So a mental health assessment should be part of follow-up as well. But again, this is just not being done by many private providers. Okay, good stuff. And then a final slide on the future. And this is where things get really exciting, I suppose, because GLP-1s are not just being studied in type 2 diabetes and obesity. Look at these studies I found recently. Parkinson's disease, some quite compelling data. Alcohol consumption, and I've definitely seen this with my own eyes. I told you GLP-1 affects the hypothalamus, Gorkem. Yeah, it takes away the reward with eating, and it increases your feeling of being full. But what it appears is it takes away the reward with any excessive behavior. So alcohol excess, pathological gambling, even hypersexuality. So it's been studied for reducing alcohol consumption. And I've definitely, anecdotally, patients have told me they are just not interested in alcohol anymore after starting on their incretin therapy. So this is potentially a future therapy for alcohol dependence syndrome as well. And dementia.
Very related question to that. So
yeah.
what would be your suggestion to use it with alcohol
abuse
problems?
Oh,
So
I would go for it, to be honest. It might help reduce alcohol excess. Yeah.
That's brilliant.
And dementia as well, it's being studied in. And then finally, osteoarthritis. And I know what you'll all be thinking. Oh, of course, you're going to lose weight. Your osteoarthritis is going to get better. But actually, it appears GLP-1s, like many other drugs, have an anti-inflammatory effect. And even in osteoarthritis, which is largely degenerative, does have an inflammatory component. And GLP-1 has been demonstrated to reduce things such as high sensitivity CRP. So we're going to hear a lot more about the anti-inflammatory properties of GLP-1s. And as we know, inflammation is the root of most evil, isn't it? So it's a...
And there's a comment about some mixed reports recently about GLP-1s reducing the total cholesterol and LDL. Is this the case? Or if so, is this due to reduction of weight, or is there any direct effects to GLP-1s?
So excellent question. I'm not aware of any direct effect. I mean, where I've seen marked improvements in lipid profile has all been related to weight reduction. So to be honest, it wouldn't surprise me if there is, possibly some direct target in the cholesterol synthesis pathway that GLP-1 affects. Because you have to remember, GLP-1 and GIP receptors are quite ubiquitous. They're found all over the body, all systems. So, but I'm not aware of currently any direct impact on reducing cholesterol, LDL synthesis, or even LDL receptor recycling. But certainly the significant weight reduction has caused marked improvements in lipid profiles in my patients. Yeah.
So, and there's another aspect of it. So the most fatal illness or the most fatal problem in psychiatry is the anorexia nervosa and any mental health issue would be GLP contraindication, because how do we stop those people to access?
Eating disorders. You don't want to go anywhere near a GLP-1 with anyone with a background of eating disorder. I mean, any other mental, depression, bipolar, these are not absolute contraindications, but definitely a full mental health assessment needs to be done and the pros and cons weighed up. But no, definitely eating disorders, I wouldn't go anywhere near a GLP-1 for the obvious reasons. It might worsen eating disorders, of course. Yeah.
Okay.
Great.
Yeah,
So I think that brings me to the end. Yeah, just a reminder of that hack again. I've covered quite a lot of this hack in this over the last hour and a bit. So do have a look. I've put the QR code up here. I mean, as I said, happy to share the slides as a PDF so you can access the QR code there. But I appreciate it's my own work and Ema's work. But I generally hope you'll find it helpful just to try and make a bit of sense of all this GLP-1 prescribing going on. So yeah, that brings me to the end. Here's my contact details. I appreciate I hit you with quite a lot over that last hour and a bit, but I hope you found it helpful. Hope you all took away one or two messages that'll make your life a wee bit easier, but ultimately help improve the lives of our patients in primary care. So thanks for listening, everyone. Cheers.
Well, that's been brilliant, Kevin. Thank you very much. And in a very important topic, as we are discussing a panacea in the world at the moment, where the healthcare is definitely in crisis. So I think this discussion will definitely take a long time in the next 5-10 years, and definitely lots of companies will be spending millions, billions to it, while patients are quite desperate. So just I'd like to ask, so when you are prescribing this kind of medications, and as a medical writer, as a scientist, what is the main difficulty that you come across when you have this, when you're being asked this kind of questions? Can we keep taking these medications? What are the main ethical dilemmas?
The main, well, I suppose every day I'm in clinical practice, I'm asked, can I start this? But it's for an obesity-related comorbidity, which I just can't do. Which is a shame because, a lot of these, we're talking about younger and younger people. You'll be aware of some of the statistics. There's now more people under the age of 40 with type 2 diabetes and type 1 driven by the obesity epidemic. So type 2 diabetes, I suppose I can start these incretins. But for people, we're seeing a significant increase in pediatric and adolescent obesity and adult obesity at younger ages. So that is, I suppose, the biggest ethical dilemma. But I appreciate, we have finite resources in the NHS, and we can't, if we open the, if we widen the criteria, as I've said on a number of times, it would bankrupt the NHS. So I find that a real ethical wrangle, to be honest, because there's patients I definitely feel would benefit from it, who are motivated to change, to lose weight, to reduce their future cardiometabolic risk. But my hands are tied. I can't prescribe it for them. I mean, the perverse thing is, if they get type 2 diabetes, I can. So it's almost like I'm telling them, yeah, just keep eating some sugary stuff, put up that HbA1c over 48, and then I can start it for you. It's perverse, isn't it? I mean, I'm kidding. I don't say that to patients, but that, that is, that is the sort of situation, we're in at the moment. So, so that, and also, yes, the other big question is, if we do start it, when do you stop it? Because as I said, no one wants to stop it. And
it definitely has to go in hand with the lifestyle changes. Otherwise,
the starting rules have to go hand in hand with stopping rules for GLP-1s. There's no doubt.
Yeah. Always need to have an exit strategy anyway, in almost in most of the medication.
Oh yeah, 100%. Be it monoclonal antibodies, DMARDs, whatever. You also have to discuss: is this a lifelong treatment? Is this a trial? Are we going to step down to something else? So yeah, same with GLP-1s as well.
And apart from the GLP-1s, I'd like to, bring up the essence of the portrait sessions, which is special interest in general practice.
Yeah.
So I'd like to ask the question. This is not your first portrait session, but could you please remind us, looking back, what were the pivotal moments or decisions that helped you to shape your such a diverse and influential career?
I mean, life's full of serendipity, isn't it? But for me, I suppose when I took on my partnership at North Berwick, the caveat was they offered me the partnership, but only if I took the lead on diabetes for the practice. So that was 15 years ago. So that's how my original interest stemmed. And then I did a master's degree. And I would just tell everyone, particularly my younger colleagues on today, stick your head above the parapets. I very early on volunteered to be the diabetes lead for the cluster, actually. I mean, we do things slightly differently in Scotland, as you know. So complete imposter syndrome then. I had no idea what I was talking about. I was just winging it. But it was a very formative process for me, and really helped me. And then NB Medical Hot Topics. I'd done quite a bit of education. They advertised for a new presenter, and I thought, oh, I'll give this a shot. I've got some good feedback, and my audition went well, and that I worked with NB Medical as one of their Hot Topics presenters for about 5-6 years. So that really helped me, do teaching on a more national basis. And then my diabetes work has taken me sort of abroad as well. So yeah, I suppose just stick your head above the parapets. That would be my main advice.
That's brilliant. So recently, a friend of mine has mentioned a Greek poem called Ithaca. Ithaca is the place that is an island in Greek mythology. And I think the general practice is such a similar thing. It's not the goal, it's the path that we are in. And you can get a lot of things during your travels.
Yeah.
So we have just one more question.
Yes.
We also have the Pathway to Remission program, which requires stopping all diabetes medications. My practice has been asked to increase referrals. How do I decide who should not try this option?
Yeah. Oh, no, I'm a big fan of diabetes remission, David, as well. It tends to be most successful for those with relatively early onset type 2 diabetes. So I've had most success, maybe patients who have been diagnosed up to 10 years or certainly up to 7 years type 2 diabetes, and maybe those not with very high HbA1c. So that's not a contraindication. And of course, we need to assess patient activation as well, but not absolutely. I mean, the original diabetes remission study was called the DIRECT trial, and I have 3 patients who were recruited into that, and they've all done fantastically well, reversed their type 2 diabetes and maintained it. But it's not a panacea like GLP-1s. Type 2 diabetes remission is not for everyone. I mean, losing 15 kilograms is no mean feat, is it? So I'd actually, as part of my master's degree in diabetes, my thesis was actually on the reversibility of type 2 diabetes. And I actually tried a 4-week very low calorie diet myself, because I thought, if I'm going to be referring this to patients, I need to know what it's like. So I ate only 500 calories a day for 4 weeks, actually. Well, to be honest, I only managed 3.5 weeks because I had a stag do I had to go to. And to be honest, it was one of the most challenging things I've ever done in my whole life. And I consider myself a pretty motivated person. But you just quickly realize the influence of food in your everyday life. Food advertising everywhere. My kids were very young at the time, so food being thrown around or very difficult. And the trials suggested that, after 3 or 4 days, you stop feeling hungry because of changes in hormones. That was nonsense. I was starving for 3 weeks, So it's not easy. I'm not trying to dissuade you from referring down the pathway, David, but you do need, you need to be careful with who you refer, because it's definitely not for everyone. So again, personalized medicine, we need to be guided by that individual, what they want, what's realistic for them, in whether we go down a GLP-1 route, remission route, or in bariatric surgery even, for others as well. Yeah.
Thank you. I had a patient, and he wanted those, he wanted a GLP-1, and I said, well, you haven't tried an SGLT2 yet, so
yeah, sure, yeah,
let's try that first.
Yeah.
And then I said, oh, actually, there's the pathway to remission.
The remission, yeah.
But it's a very low calorie diet, and maybe I kind of overemphasized that, it's really low. And he goes, to be honest, I wouldn't be able to do that. So fair enough.
But remember that the calorie deficit diets, I know that the DIRECT trial was only 600 calories for men, I think, and 500 for women. But, for some of my patients, they're just dropping by 500 or 1,000 a day. So instead of taking 2,500 calories a day, they're taking 1.5 or 1. And, with time, You know, it's not rocket science, is it? That results in total calorific restriction, which leads to weight loss. So you can individualize the calorific restriction. Yes, the studies were done on these extremely low calorie diets, but as you and your patient said, 500 calories a day is just not realistic for many of our patients. You know, perhaps particularly those who are living with obesity, who are probably taking in 4,000, 5,000, 6,000 calories anyway, you know, as baseline. So we've got to be realistic in what's achievable. Cutting someone from 4,000, 5,000 calories to 500 is just not going to work, is it? So halving it, you know, to 3,000 might be more realistic for something like that, someone like that, and make it more of a sustainable option.
Absolutely. Thank you so much for the questions, David. I did the same thing. I did the calorie deficit diets sometime as well, and I really found that instead of taking the calories out of your diet, you stop eating rubbish. And then because all these, you know, junk food is like more than your daily, definitely more than your meals.
Yes.
So if you had one bag of sweet, it's basically your meals completely, and you cannot eat anything else if you do that. And to be able to continue your meals, you just cut down the junk food.
So the figures, I mean, the dietitians debate this a wee bit, but 1 kilogram of fat is equivalent to about 30, no, sorry, let me get this right. 1 pound of fat, I'm getting 3,500 calories. Yeah, no, it is 1 kilogram. 1 kilogram of weight, fat is about 3,500 calories. So if you drop 500 kilocalories a day over a week, 3,500 calories, you should in theory lose about 1 kilo. Of course, you've got to bring in basal metabolic rate and there's other extraneous factors. But I like sharing that sort of figure with my patients, you know, just something, you know, to aim for broadly, you know, and even a small calorific, you know, 500 calories, I think is realistic for many of us, isn't it, to reduce. So just having these small realistic goals that patients can strive for rather than, as I said, going straight for the 500. But there's no doubt some of my patients just want that strict target, 500, that's it, and you've seen immense. So again, individualization of care is the way forward here.
That's amazing. So we have 5 minutes left, and that's been a brilliant webinar. And the last comment was Dr. Fernando is a star.
Is a what? Sorry?
Dr. Fernando is a star.
Oh, star. Thanks. Thank you.
So thank you so much for everyone for attending and coming in. And so thank you, Kevin, for coming in again, because the last time that we had this webinar, it was the SGLT2.
Yeah.
And we were talking about what are the advancements in medicine. And we were very concerned about how we're going to catch up. It's been possibly 6 months, and now we are in a complete different position than, not completely, but almost a different position than we are approaching the diabetes now. So yeah, thank you so much for coming back again and being with us, and everyone, thank you so much. So this webinar has been recorded, and we will send the recordings to all of you, and you can find Kevin on social media, and you can find West of Scotland faculty and social media, first by in Twitter, formerly known, now it's X, and please follow up the RCGP Scotland Twitter account as well for further portraits.
Can I do one last little plug? This is, I know everyone will laugh, but I have a YouTube channel with some patient-facing videos on SGLT2s, and I'm also going to do ones on incretins, actually. So if you have some time, have a look. My kids are all mortified. They've all unfollowed me online, but they've all unfollowed me in real life as well. But I've got 4 videos on what SGLT2s are for patients. I've got 6 videos on lifestyle and type 2 diabetes. So I've produced these completely independently, no conflicts of interest. So if you have some time, have a look, and we just text out links to these videos for our patients, just because there's a lot to cover, isn't there, about SGLT2's lifestyle and a 10-minute consultation. So if you have some time, do have a look. Yeah.
Absolutely. If you go onto YouTube, don't forget to look for beneficial stuff to yourself as well. Don't just scroll down.
Great.
Yep, that's amazing. And thanks everyone for coming in again.